And in B-cell malignancies, BTKi inhibits that BTK enzyme, which is very upstream. It tells NF-kappa beta to stop signaling into the nucleus, and then inhibits proliferation and survival of B cells.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Puja Patel, Clinical Oncology Pharmacist at Northwestern Medicine Cancer Center at Delnor Hospital in Geneva, Illinois, about the B-cell receptor pathway inhibitor drug class, specifically the Bruton's tyrosine kinase inhibitors. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome and thanks so much for joining us today, Puja.
Thanks for having me.
So to start things off, let's start with a brief overview on the history of the B-cell receptor pathway inhibitor class in the field of oncology.
Discussing the history and the background is so important to understanding kind of the bigger picture of these medications for your listeners. So I really want to spend a little bit more time here because this information was really buried in the literature. So let's start from the beginning of what is a B cell. So B cells are born in the bone marrow. So that's B for bone marrow. And about 1 billion, yes, billion with a B cells are produced each day during the entire life of a human. So even your elderly patients are making that many B cells. And the function of a B cell is to differentiate. So meaning, what am I going to be when I grow up? Taking on a specific role. And so they make a career choice. And it's not really a tough career choice because a B cell really only has two fates, either to become a memory B cell or a plasma B cell, which is an effector cell where they actually make something. And plasma B cells are antibody factories, and they make a specific antibody that uniquely binds to a specific pathogen. And some plasma B cells can produce over 2,000 antibodies per second. They really are heroes in our bodies, but they only live a few days. What's amazing here is that each B cell is programmed to create one type of antibody. The only difference from an antibody versus a B cell receptor is that the antibody is free to roam around the body, and the B cell receptor, which is the same exact version of that, is just membrane bound to that surface of a B cell, meaning the B cell can be programmed to detect one specific antigen, or we can think of it kind of like an invader to simplify it a bit. And it has two ways of finding that invader. It can either, as it matures, its soldiers or one type of antibody can go out into the body, or it can keep its soldiers kind of at the fort, ready to attack on the B cell if the pathogen just happens to float by. It's fascinating that each B cell can have over 100,000 B cell receptors. And so now kind of just talking about the B cell receptor, it functions really as the eyes of a cell, and it has 4 parts specifically. So if your listeners can kind of think about the immunoglobulin that they have seen in images, you can bring that to your forefront of your mind and imagine the Y of the B cell receptor, and it's comprised of 2 proteins. So we have a heavy chain and a light chain, and that's the recognition part. And then these parts allow the B cell to recognize the antigen, which is that foreign matter. Right now, we're still on the outside of the B cell. And then it signals, a signal has to be sent from the surface to the inside of the B cell where the genes are involved in activating the B cell. And that can be whether it's being turned on or off. And those 2 signaling parts are made up of 2 other proteins, and that's called CD79A or B. So that's a little bit about the B cell receptor. And before we go on to further signaling, I just want to talk a little bit about the history of one of the key players that we'll be talking about today, and that'll be in the downstream signaling pathway. So let's start our history lesson, Jaime.
I'm ready.
Okay. In 1952, we have pediatrician Colonel Ogden Bruton of Walter Reed Hospital, And he described a congenital disease in babies that were born with severe immunodeficiency. So these children were continuously present with infections like bacterial sepsis or osteomyelitis or otitis. And this was due to what he discovered as a lack of B cell maturation and X-linked agammaglobulinemia. So they had really slow serum level immunoglobulin concentrations. And it wasn't until 1993, so for us, it's only 32 years ago, that Professor David Vetri, the translational leukemia genomics, discovered the cause of that immunodeficiency was due to a mutation in a specific kinase. And they named that kinase after clonal Ogden-Bruton, and they called it the Bruton's tyrosine kinase gene, which I'll refer to as Bruton's tyrosine kinase, or BTK, from now on. It's critical in the B cell receptor pathway, and Vetri defined the structure and the function of BTK. Later, it was then discovered that BTK is also expressed in malignant B cells. BTK is vital for the development of B cell lineage and the survival of the B cells. So, malignant B cells, BTK becomes really overexpressed and continually activated, thus allowing that cell to survive and thrive in the peripheral blood, in the bone marrow, and in the lymph nodes. So in 1952, we have the discovery by Colonel Ogden-Bruton of that severe immunodeficiency due to lack of B cell maturation and X-linked agammaglobulinemia. In 1993, we had Professor Vetri and colleagues discover that this was actually due to a mutation in a kinase, and they called that BTK. And then in 1993 was a discovery of our first BTKi inhibitor in the lab setting, and that's called LFM813. And it wasn't until 2013, that's 20 years after BTK kinase was discovered, where ibrutinib was our first in-class BTK inhibitor. And the success of ibrutinib really promoted the exploration of second and third generation BTKis. So in 2017, we have acalabrutinib, a second generation. In 2019, we have zanubrutinib, second generation. And then in 2023, we have pirtobrutinib, which is our first non-covalent BTKi, and it's deemed a third generation BTK inhibitor. So we have a really nice table for your listeners that we'll provide that just has a list of the BTK inhibitors, their generation, their inhibition, and their indication.
Well, Puja, I've been a nurse for about 19 years, and I think I've learned more in the past 7 minutes than about B cells. To be fair, I've worked mainly in solid tumors, so that'll be my excuse, but absolutely outstanding. Thank you so much for really starting way at the beginning, walking us through that. Certainly gives us the context, the foundation of information that we need to continue our conversation today. So thank you so much for that.
My pleasure.
So let's move on now to talk a little bit more in depth about the mechanism of action. Can you discuss that in a little bit more detail about how the BTK inhibitors actually function?
Today's discussion will talk about the B cell receptor pathway and specifically focusing on one signaling pathway. So there's many signaling pathways. We'll focus on one here today. And the key player in this pathway is the Bruton's tyrosine kinase. So let's just start with what is a kinase. Protein kinases are enzymes that catalyze or just speed up phosphorylation of proteins. And one type of kinase that's critical in oncogenic signaling is BTK. So first we'll dive into what a normal BTK signaling pathway kind of looks like. So recall that we just talked about the B cell receptor. It's always coupled with CD79A and B, which is also called a heterodimer. Think about B cell receptor on the outside of the membrane like the arms. And in order to send that signal down all the way inside the nucleus, it needs some legs. And those legs, they first start off with this heterodimer set, which is the CD79A and B. And so when an antigen binds to the extracellular B cell receptor, this triggers a phosphorylation of that set. And then Lin, which is a proto-oncogene, also a tyrosine kinase, phosphorylates the heterodimer set, CD79A and B, and then activates SYK, which is a splenic tyrosine kinase. And ultimately, SYK leads to the phosphorylation and activation of BTK. Now that BTK is activated, it eventually signals NF-kappa beta, which is then freed up to travel inside the nucleus. NF-kappa beta is a transcription factor, so its job is to go inside the nucleus and turn things on or off, to proliferate, survive, include migration or maturation of the cell. So this is kind of a big picture. There's many, many proteins that were not discussed just to kind of simplify the mechanism here. And then for your listeners that would like to see a video, there's a great short clip by ASCO about understanding the pathway, and I'll send that to you for show notes. Now let's talk about the BTK pathway in the B-cell malignant cell. So it's thought that BTK and other members in the pathway are constitutively phosphorylated, which just means they're spontaneously on. This leads to this uncontrolled activation of NF-kappa beta signaling and thus uncontrolled proliferation and suppression of apoptosis. So these B cells are rapidly dividing, but they're not functioning like they're supposed to be, meaning they won't differentiate or, they won't grow up to be either a plasma cell, like we talked about, or a memory B cell. They've been hacked, and they've been hacked to just multiply, but not function. And so, Jamie, you can think about this. It can lead to numerous detriments. Now, we'll kind of go into the actual mechanism of the BTKi inhibitors. So what are they doing? They're blocking the signaling at this BTK enzyme. And so we have our agents that we just talked about, ibrutinib, acalabrutinib, zanubrutinib. These three agents all irreversibly, covalently bind their inhibitors to that BTK and a specific point, a cysteine 481 residue in that kinase pocket. And this disrupts ATP binding, blocking the enzyme phosphorylation and activation, which we just learned is really important in upstream kinase involvement in B-cell signaling. And so by irreversible, what this means is that even after the drug is metabolized, BTK is still irreversibly inhibited until new BTK is generated. And this is what allows that once daily dosing, even in the presence of a shorter half-life. Pirtobrutinib, which is our first non-covalent reversible BTK inhibitor, just approved recently in January 2023. And now that inhibits both wild-type BTK and BTK with cysteine 481 mutations. And this is our only third-generation BTKi. And unlike the first and second-generation BTKi, it does not rely on binding to that cysteine 481 residue, which is often a site where mutations and resistance are developed. It works by binding and blocking the ATP binding site of BTK, but this binding is not dependent on C481. So it's a different mechanism, but using the same pathway. So just to kind of summarize, B cell receptors are located on the outside of the cell. They receive a signaling and then they're activated. This activation then sends messages to BTK inside of a cell. And then BTK sends several messages, finally getting to NF-kappa beta, which travels inside the nucleus and then tells the cell to continue proliferate and suppress apoptosis, meaning it just says all gas and no brakes. And in B-cell malignancies, BTKi inhibits that BTK enzyme, which is very upstream. It tells NF-kappa beta to stop signaling into the nucleus, and then inhibits proliferation and survival of B cells. I also have a few images that will be very helpful for visualizing some of these steps that I discussed, Jamie.
That's wonderful. And I really appreciate not only sort of the analogies and the pictures you help us paint in our minds as you describe it, but of course, any actual visuals to reference will be wonderful and helpful for our listeners as they listen and kind of reflect on what we're learning today. So that will be wonderful to include in the episode notes. So now let's move on to, you've already mentioned a little bit in some of the earlier discussions about some of the different generations of these agents. So let's revisit, and I would ask if you could highlight some of these examples of both some of these original agents as well as the newer agents that we're seeing in the BTKi class.
This class is generally called, if you think of an umbrella term, it's just called targeted small molecule therapies. Now, a subclass is BTKi or Bruton's tyrosine kinase inhibitors. So we're really shifting away from the use of cytotoxic chemotherapy, which is kind of designed to indiscriminately destroy rapid dividing cells, to a more precise approach of targeting cells based on specific molecular changes in tumor DNA. So as I mentioned, kind of the first one to market, and there was a lot of great hype about this drug, is ibrutinib, or a brand name Imbruvica, in 2013. Our first second generation, or is kind of a Me Too drug, you can think about it, was acalabrutinib, or Calquence, brand name, in 2017. Our next second generation, also another Me Too drug, was zanubrutinib, or Brukinza as brand name, and developed in 2019, FDA approved. And then our newest kid on the block that uses the BCR pathway, but in a different mechanism is pirtobrutinib or Jaypirca, and that was FDA approved in 2023. So let's just talk a little bit about why we had to have this discovery of a third generation BTKi inhibitor. Researchers evaluated why were patients becoming resistant to these first and second generation BTKis. And one mutation that caused resistance was at that cysteine 481 amino acid site. And this mutation changed ibrutinib to a reversible inhibitor, which resulted in decreased efficacy and resistance and allowed more BTK to be active, leading to progression. So if patients develop a mutation at that cysteine 481 site, since the mechanisms of all the first and second generation BTKIs are identical, the resistance that really occurs across all three drugs. So pirtobrutinib is designed to overcome one of the most common mechanisms of resistance, and that's the mutation in BTK at that C481 site. And it really has two claims to fame. The first is selectivity. So pirtobrutinib is 300 times more selective for BTK than other kinases, which means it just has a better safety profile because there's less off-target kinase activity. And then it has a long half-life, 19 hours. But and this is permitted because pirtobrutinib is reversible, you need a long half-life. And so that you're constantly kind of binding that BTK, no matter how much that cell is turning over. At the 200 milligrams once daily dosing, this results in a 96% BTK occupancy throughout the entire dosing intervals. Versus acalabrutinib and zanubrutinib, they have short half-lives, so they have to kind of covalently or tightly bind to BTK because their goal is to shut down BTK until more BTK produces.
Thank you for that. That certainly is helpful to understand how those, not only did the generations kind of develop in succession, but why this latest generation is different and how that is helpful. So thank you for that explanation. Let's move on now into talking about the toxicities and some of the adverse events. What are some of the most common toxicities that we see with these BTK inhibitors? And are there any differences between the generations or the individual agents?
It's really kind of important to understand why some of these toxicities are occurring. And toxicities occur based on the selectivity of BTKi to the BTK versus off-target sites. So the more off-target binding there is, the more side effects there will be. And the more select the BTKi is, the less off-target binding there will be, and thus less of those kind of off-target side effects. So some adverse events are linked with specific off-targets, and I'll share those. Thinking about the subclass, BTKIs are most known for their cardiac side effects. And they come in the forms of like atrial fibrillation or a flutter. And this is specific because of the off-target binding at CSK, BMX, ERBB4, which is in the cardiac cells, hypertension, and then less frequently ventricular arrhythmia. They are also known for bleeding. So BTK inhibits both the BTK and the TEC-K family kinases, which are on platelets. And then arthralgias, which could be due to EGFR binding. Infections, cytopenias, diarrhea, which could be because of EGFR in the GI tract binding. And then fatigue. Thinking about the individual adverse events, acalabrutinib is known to have headaches, which we'll talk about later and how to mitigate some of those side effects. And then additional toxicities include dermatologic toxicities, and that's because of the off-target EGFR toxicity. And you found a really nice infographic kind of simplifying these toxicities into a one-pager provided by Ash that we'll provide for your listeners in the show notes.
Wonderful. And I really appreciate how that description that you provided helps really acknowledge that, yes, these are targeted agents, but there are still sort of these bystanders that get involved. Even though they're hitting the target that we want, there are some off-target impacts. And that's, as you mentioned, that's where a lot of these toxicities present themselves, because while they are specific, there's still that opportunity for those off targets to be involved. So I appreciate you kind of setting that up as sort of what underlies some of those toxicities.
Yeah, and I was kind of thinking about this myself, Jeannie. You know, when you have a dart, if your dart is your medication and you have the dartboard in front of you, when you're kind of aiming right at the center, which is your BTK, that dart kind of splits before it can even get to the target point. And maybe 50% of it gets into the middle and the other 50 kind of scatters. And that's kind of what is happening with these side effects.
So then let's move on into some of the ways to prevent or to manage these toxicities. What are some of the pharmacologic strategies that we can use when considering managing the BTKi toxicities?
I'll spend a little bit more time here because nurses really play such a vital role in prevention and management. So I'll take each of these adverse events of special interest one at a time and kind of break down the onset, the mechanism, and then prevention and management strategies. So let's start off with the toxicity that is often an important deciding factor for prescribing, and that's cardiac toxicity. So cardiac toxicity can manifest as atrial fibrillation. And here I'll specifically talk about ibrutinib values because we have the most data with it, and the numbers actually get better with second and third generation BTKIs. So frequency, grade 1 to 2 atrial fibrillation was reported in 12 to 15% of patients on ibrutinib, and grade 3 AFib is 3 to 5%. The onset, median onset is 8 to 13 months. And the mechanism of action is inhibition of CSK, PI3K, ATK, and ion channel pathways, which play a major role in cardioprotection and is regulated by BTK and TEC. We should obtain a baseline EKG and blood pressure. And for patients that have more than one cardiac risk factor, which would include age over 50 or prior cardiac arrhythmias or hypertension, heart failure, moderate or greater valvular disease, any prior cardiotoxic chemotherapy, a baseline echo is also recommended. There is a scoring tool available for measuring individuals' risks for AFib. And now, if AFib develops while a patient is on a BTKi, it's important to note that the BTKi actually can still be continued at a reduced dose or interrupted until those symptoms resolve. So I vividly recall a patient that I had that came into clinic and was actively having arrhythmias while on ibrutinib. He had been on it for about a year, and after managing his arrhythmias, we lowered his dose of ibrutinib, and he continued on this medication successfully for several years. So successful resumption of ibrutinib after AFib really has been reported, and permanent discontinuation is not required. And the PI has dose recommendations for these patients. And in patients who have disease control, who develop AFib, it could be reasonable to switch over to Acala or Zen as well. We want to obtain a cardiac oncology consult. So not all practice sites have this. Unfortunate that my practice site has this specialty available. And AFib actually increased also, as your listeners are probably aware, the risk of stroke. So you should calculate for the stroke risk. We're using the CHADS-FAST-2 score and recommend anticoagulation for those patients that are at increased risk. And of note, warfarin is not recommended with acalabrutinib and ibrutinib because in the early ibrutinib studies, while patients were on these, when they were combined with warfarin and ibrutinib, it actually increased the risk of major hemorrhage. And thus, these patients were excluded from all subsequent BTKi trials. Of note, zanubrutinib, when they did their trials, except the Alpine study, allowed warfarin, and based on the NCCN, warfarin is permitted with zanubrutinib. NCCN also says that you should not use more than 3 antiplatelet agents. So you shouldn't be on a BTKi. They call out aspirin, antiplatelet, and a direct oral anticoagulation agent. So when thinking about direct oral anticoagulation agents, they are preferred over dabigatran because dabigatran has more renal adjustments and it's also a PGAP inhibitor, which interacts with amiodarone, which you might be on for rhythm control. So it's recommended to maybe be on apixaban or rivaroxaban or endoxiban, and the latter two can be considered because they are once daily, and for patients where adherence is a barrier, that can be great options. We have rhythm control. So for rhythm control, all BTKi inhibitors are major substrates for CYP3A4, and several rhythm and rate control agents actually interact through this pathway. So talk to your pharmacist because I personally have experienced so many patients on these combinations where we've actually mitigated these interactions due to my direct patient care clinical practice. So for example, diltiazem and verapamil, which are moderate inhibitors, non-dihydropyridine calcium channel blockers, they can increase ibrutinib's toxicity. And so the PI calls out that ibrutinib should be decreased when combined with moderate CYP3A4 inhibitors. And then rate control, beta blockers such as metoprolol can be used to manage the AFib. cardioversion or ablation, and then our options. And then really just note to listeners that all BTK inhibitors have specific recommendations and for managing their AFib in their PI. So I would really refer to that for some details. And so that kind of wraps up just the AFib section. We have some more sections to cover. So looking at bleeding and major bleeding. So minor bleeding, such as BTKi or bruising, are seen, as well as major bleeding like hemorrhage and serious bleeding like intracranial hemorrhage have been reported for this specific class. And all grade bleeding ranges from anywhere from 36 to 51%. And major bleeding is a lot lower, it's at 2 to 5%. And this could be because of the TEC family kinases, which really help facilitate platelet activation. And when inhibited, the coagulation is impaired, eventually leading to less platelet aggregation. And then there also is data suggesting that BTK inhibitors increase the risk of bleeding by impairing like this collagen-induced platelet activation, which is akin to the effects of aspirin. So there's inhibition of SRC kinases, which are associated with bleeding, and acalabrutinib actually has less inhibitory potential with respect to SRC, so perhaps it has less bleeding risk than ibrutinib. For minor bleeds, it's really reasonable to hold the BTKi for 2 to 3 days, and additional precautions is recommended during surgeries too. So you should be holding a BTKi 3 days before and after a minor surgical procedure, and 7 days before and after a major surgical procedure. And we just had a patient that we recommended this for in my clinic that was having dental extractions and, several teeth pulled out. So our BTKi will be held for 3 days before and after that procedure. Moving on to hypertension. So we have, looking at the onset, it's about 6 months. The mechanism is due to impacting PI3K ATK pathway and leading to this downregulation of nitrous oxide production, which makes sense. And incidence is 7 to 23%, depending on the BTKi. And risk factors include hypertension, prior blood pressure management, history of antihypertensive use, and the guideline-directed therapy is really the therapy of choice for managing blood pressure. Hypertension for grade 3, you should be holding based on the PI for ibrutinib and resume after grade 1 in recovery. And then for acalabrutinib, there is a recommendation to hold and then also resume at 100 milligrams daily, which is half the dose. Moving on, we have some more adverse events to talk about here. So here in Chicago in January, it's the heart of winter season, also virus season. So we'll talk about infections next. The diseases that BTKIs are used for themselves actually predispose patients to an increased risk of infection through the dysregulation of the immune system. So that is a risk factor itself. And then these patients kind of that we talked about maybe have hypogammaglobulinemia, which is common because of the mechanism that we referred to. And this could further increase the risk of infection. And then third, the BTKIs themselves can actually decrease the function of T cells, NK cells, monocytes, macrophages. So you're really looking at both your innate and adaptive immune system being both intrinsically and extrinsically weakened. Grade 3 infections occurred in 17 to 24% of patients with BTKIs, and upper respiratory tract infections were the most common among all BTKIs. PJP occurred for patients 0 to 5.6% incidence, and thus the role of PJP prophylaxis is unclear in this setting. And so you should manage by evaluating the risk of initiation based on risk factors for PJP. And then patients should receive the following vaccines ideally before they begin therapy based on the NCCN. So looking specifically for the CLL guidelines here, they recommend annual influenza, pneumococcal vaccine, zoster vaccine recombinant for all patients treated with BTKIs, RSV vaccine, so that's single dose vaccine for patients, including those that are less than 60 years old, and then the COVID vaccine for all these patients as well. And I have been referring a lot of my patients that I've been getting a lot of questions recently because of the RSV still fairly new, and then COVID, is a kind of a maintenance vaccination that patients often inquire about this time of year. Certain antivirals can cause interaction with CYP3A4 substrates, so we should hold a BTKi while patients receiving these antiviral treatments. So just double check with your pharmacist or your nurse about drug interactions. And then nurses really should be aware of signs and symptoms of infection and then kind of educate the patients on how to contact their oncology team. And then nurses can also gather data about comorbidities. like concurrent immunosuppressive agents or corticosteroids that could increase the risk of these opportunistic infections. So from infections, we'll kind of talk about neutropenia because neutropenia is a common side effect, whereas thrombocytopenia and anemia are a little less prevalent in this setting. The PI has specific recommendations for dose reductions for each of these BTKIs. And of note, I did find that zanubrutinib has slightly more neutropenia, and especially based on the Alpine study of 21% versus ibrutinib, but this does not translate to a higher rate of infection. So it's kind of important to kind of distinguish that. And then we have 4 more adverse events to just quickly discuss here. We have arthralgias and myalgias. So musculoskeletal pain, including myalgias and arthralgias, are less serious, but they can be really troublesome, Jamie, for our patients. They can lead to discontinuation. And it's one of the most common side effects, occurs in 32% of patients with acalabrutinib based on the Elevate-TN monotherapy study. Management and dose reduction can be thought about for these patients based on their effectiveness of daily living activities. So there is some anecdotal evidence with using magnesium supplementation, which can help. And then there's also some evidence using quinine-containing tonic water, but I would kind of caution listeners to that because there is potential of EKG prolonging. So kind of beware of that if you come across that in the literature. And several arthralgias also can be treated with a short course of NSAIDs. So just keep in mind that maybe there's an increased risk of infection or bleeding, but that can also be a pretty good option. Nurses should obtain a detailed history, including the degree of impact of the pain has on the patient's activities of daily living. And I recently had a patient over the springtime that was an avid gardener, and we just started one of these agents, and it was really impacting his quality of life because he couldn't get on his knees and mend to his garden. And so we managed this appropriately so he could continue that important daily life activity. And he was able to continue his gardening over the spring and summer. And then lymphocytosis is kind of a unique feature for BTKi therapy. It's a very important teaching point to discuss with patients because a lot of these times they're following that absolute lymphocyte count very closely. And so to note that and educate that this is not a sign of disease progression because BTKIs induce redistribution of those malignant cells that have kind of created a home in the tissues and basically vacates them out into the blood. And that's what causes the rapid shrinkage of the lymph nodes. But then this redistribution or kind of this eviction process causes an increase in absolute lymphocyte count into the peripheral blood, which is transient. So in general, lymphocytosis occurs within the first month of BTKi initiation and has a median time to resolution within 12 to 14 weeks. Incidence of diarrhea is 16 to 42% across all BTKIs, and holding BTK inhibition for grade 3 diarrhea, which can be an example, is increase of more than 7 stools per day over baseline. And then managing using supportive care measures or increasing your oral fluid intake, getting some anti-motility agents. And then for those once daily BTKIs, maybe a nighttime dose is recommended. And then our final adverse event is headaches, specifically for acalabrutinib. This occurs in 39% of our patients and is the most common adverse event experienced by patients receiving acalabrutinib. The mechanism's a little unclear. It's concluded maybe that it's due to this calcitonin gene-related peptide agonism, CGRP agonism, and the onset really occurs early in the course of treatment. Within the first 2-3 weeks, it's mild and of limited duration, and these headaches occur within 30 minutes of dosing. We don't need too much medical management. It can be effectively managed with acetaminophen, or my best advice is caffeine and avoiding any NSAIDs. So most of my patients are just happy drinking an extra cup of coffee, and it's a great way to manage the side effect. For nurses, they should really advise their patients that the acalabrutinib headaches are easily managed, and they will decrease over time over a period of 4 weeks. This is an upfront conversation reassuring the patient that this is not a long-term side effect. So that wraps up most of the common adverse events and their prevention and management strategies, Jamie.
Wonderful. Well, I just really appreciate the depth and the detail that you spent discussing those, because that is where we as nurses spend most of our time when we're talking with patients and helping to not only assess them for the adverse events that they might be experiencing, but also then give them that information, whether it's ahead of time or as they're experiencing it. So really, really appreciate the time and detail that you spent discussing that. Now let's move on into some of the administration considerations. So these are oral agents. So what are some things that nurses should consider as they are working with their patients who are starting to take these BTK inhibitors?
One of the things that kind of comes up I've seen when this class is prescribed is when educating or when our APPs are prescribing this medication, there's an interaction that pops up with specific with acalabrutinib and PPIs. And if this still kind of pops up in your EMR or your drug database, just know that it's no longer valid. I specifically recall a patient where we wanted to use acalabrutinib a few years back, and we were kind of on the fence about using this because he was on PPIs chronically. And we were kind of in the weeks of making our treatment decision. So at that time in 2022, acalabrutinib actually reformulated its product from capsules which interacted with PPIs and antacids to tablets that no longer interacted with antacids and PPIs. So this mitigated this interaction, and it's really crucial because now we can allow more patients to be offer acalabrutinib who are on chronic PPIs. So the bottom line is if you see acalabrutinib and a PPI interaction that's no longer valid, acalabrutinib, PPI, and antacid is okay to use. And the other aspect is when patients are progressing, yes, these are oral agents, but it's really important that BTKIs are not just stopped when patients are progressing because there could be this kind of withdrawal syndrome where patients can present with fevers or rigors or night sweats, and it could resemble something like sepsis. And now it's important because our patients are maybe already prone to sepsis. So it's really kind of important to differentiate and understand the difference between those.
Wonderful. Well, let's move on now into just more general education points. What are some of the primary patient education points, pearls of wisdoms that we should communicate to our patients and their caregivers when they are starting these agents?
We discussed at length kind of the toxicity. So I would definitely highlight those toxicities and also discuss kind of drug, food, and drug supplement interactions with patients and caregivers, because oftentimes these may not be on the med list, or patients just might be taking on PRN, or they might be kind of introducing them into their diet because of the prognosis that they have. So turmeric supplements and BTKIs, for example, turmeric inhibits CYP3A4 and can cause an increase in BTKI. So that I would caution. Vitamin E supplementation induces the metabolism of CYP3A4, thus reducing your BTKI. And it also, more than 800 units, seems to inhibit platelet aggregation and kind of antagonize the effects of vitamin K dependent clotting factors. So it could pose as a bleeding risk. Digoxin, which is a PJP substrate, can be increased with ibrutinib or zanubrutinib or pirtobrutinib. And so these agents kind of have to be monitored. So you would really need to monitor your digoxin level at that time. And then inducers such as over-the-counter St. John's wort. You know, if patient's taking something like that, you want to make sure that you educate them to not take this combined because with the BTK because it reduces our levels of BTK. And then grapefruit juice is a known CYP3A4 inhibitor. Even a single grapefruit or 200 mLs of grapefruit juice can cause relative escalation of drug concentration and affect toxicity of the drug. And then also Seville oranges, which are found in marmalades, can cause a similar problem. And another point that I came across in clinic when providing some education for a patient for deciding between zanubrutinib. So we're deciding between a once daily dosing or twice daily dosing for this. And the question kind of came up, well, is one better than the other? And it's really important to highlight that they both have the same efficacy in terms of maximum inhibitory values and sustained 24-hour inhibition of BTKi. So you can either take the 160 milligrams BID or the 320 milligrams BID, and you have the same efficacy, which I think is important to highlight when making that decision.
How do you see pharmacists and oncology nurses collaborating to help best manage these adverse events, these toxicities, and provide this patient education? As you've given us all this great information, lots to manage and lots to make sure that we're communicating effectively. So what are some of your thoughts on how we can collaborate best to achieve this?
At our practice, Jamie, we have a really unique setting at Northwestern Medicine Delnor Cancer Center, and where we have an integrated ambulatory care oncology pharmacist in the clinic. So we're kind of seeing these patients with the provider and managing some of these toxicities. So if a patient reports any of these changes, those issues can be addressed real time with a pharmacist in clinic. So that's a really great model. And then collaborating to provide patient education. So our nurse practitioners at our center provide patient education to all of our patients who start new therapies. And so at that visit, if there's any drug interactions, like, as aforementioned, or access or formulation questions, we have the pharmacist available to work together with our nurse practitioners to address any of those questions kind of immediately and help find resolution. And then our nursing and pharmacist colleagues really serve as a trusted source of information because oftentimes our patients see them more often and for longer visits. And so patients are really comfortable opening up to them with their questions, with their toxicities, because sometimes they're not comfortable speaking to the provider because maybe they don't want the provider to take away that drug, where they may not be aware of that there's dose reduction possibilities or even holding doses. So I think developing that relationship is really important between the pharmacists and the nurses.
So, Puja, what do you think the future looks like for these agents and what their role is in the landscape of cancer care?
Jaime, this was a very exciting space for novel agents and combinations for me to kind of look at because I've been treating these patients specifically in my clinic for 6 years now, and I didn't have some of the options available back then. And, now we have pirtobrutinib, which is available. And looking into the future, I found some more exciting options available. We're really trying to look at improving overall survival and quality of life. So looking at some combinations, we have second generation BTKis and a BCL2 inhibitor specifically called venetoclax combined to create synergistic effects. So that's kind of being looked at right now. So there's zanubrutinib and venetoclax in the Sequoia arm D, and then a BTK inhibitor plus venetoclax in the MAGIC study, looking at acala plus venetoclax or venetoclax plus obinutuzumab. And then there's a new agent called nemtabrutinib. So it's not out yet, but it's being studied. It has the same mechanism of action as pirtobrutinib, which is reversible and a non-covalent BTKi inhibitor. It's in the phase 1, phase 2 safety and efficacy trials. And their trials are called BellWave. So it's BellWave 001 is looking currently at this agent, and it's a non-covalent pan-TEC and pan-SRC inhibitor. And it has other targets outside of BTK that could be important to the treatment of CLL, which what they're looking at. There's the BellWave 008 study, which is a phase 3. So this is looking at chemotherapy versus nemtabrutinib, and we're looking at first line. And then there's the 011 BellWave study, again, phase 3, nemtabrutinib versus acala or ibrutinib in the first line setting. And then 010 phase 3, looking at nemtabrutinib plus venetoclax versus Rituxan plus venetoclax in the second line. So we have those agents, combination and new drugs. And then we have this exciting new class of BTK degraders. And these drugs use ubiquitin proteasome pathway to ubiquinate. And ubiquinate is just a fancy word for saying tagging for destruction. So this drug is able to put a flag on BTK and say, take this away, leading to proteasomal destruction of BTK, which degrades the wild type and the cysteine 481 mutated BTK. And so those drugs, I'll list them, they're all like numbers and names. So there's NX2127, UBX 303061, and BGB 16673, which are all being evaluated as BTK degraders. And this new class is really exciting to me because it can provide an alternative method to BTK inhibition. And it is actually getting rid of the BTK enzyme and preventing any downstream alternative pathways that could have developed as resistant mechanisms. And then we have another class, which is also exciting. It's called the bifunctional BTK inhibition. And this is where you have two mechanisms in one. So you have irreversible binding at the wild type C481 and then reversible binding at the cysteine 481 mutated site. And that's another great option that's kind of being evaluated in clinical trials. So to look at these trials that I mentioned, you can go to clinicaltrials.gov and look at all of these studies. So those are the future agents that we kind of explore. The other aspect for the future is really looking at timing. So finite treatment is really a focus of interest here because we eventually want our patients off of treatment. So time-limited triplet therapy is being evaluated, where they're looking at a BTK inhibitor plus venetoclax plus obinutuzumab. That's kind of what the future looks like, and it's really great perspective for our patients.
Absolutely. Sounds like there's some exciting things potentially to come down the pike. So something for us to keep our eyes on. And I think this podcast episode will continue to be a good source of information as those new agents potentially come out. Puja, thank you so much. So much information. I was not kidding. I feel like I've learned more during our discussion today than I probably ever knew. And again, I'll give my excuse as being mainly in solid tumor a part of my practice, but certainly really exciting and great information to share with our listeners. So I'm so excited for this to be something that they can reference and use in their practice. As we reach the end of our episode, we'd like to always run through just a quick series of questions to help highlight and summarize some of the points that we discussed today. So to start that off, how do you think healthcare professionals can evaluate their hidden or their implicit bias about B cell receptor pathway inhibitors, but specifically for these BTK inhibitors?
Implicit bias is kind of having this unconscious association between any social group or group. And it's implicit, meaning that you're not even aware of your own bias. And so there's this IAT test, which was developed in 1998, and it's the implicit association test by researchers at Harvard. And they developed it for evaluating a valid measure of implicit bias in research. And it's tests for your subconscious associations between unique objects, which are proposed mechanisms leading to this implicit bias. And you can kind of go to Google and type in implicit bias Harvard or visit implicit.harvard.edu, and you can click on take a test. There's several categories, which I learned. It's not just one test to evaluate your personal implicit bias, but you can evaluate your bias based on race for BTKis or maybe gender, disability, etc. And so I would take this test and these tests and kind of analyze your own biases, because your biases could be due to society. Our biases could be due to media or upbringing. And then we can evaluate ourselves and then seek tools that could lead to closing our own personal gaps in health equity. And when I was doing some research for this podcast, I actually came across an episode by Cancer Horizons titled Championing Diversity in Nursing and Oncology. And one aspect that was being discussed at length was kind of identifying biases and then methods to neutralize those biases. So I think first you have to identify what your bias could be towards the BTK. Maybe it's age or comorbidities or side effect profile. And then how can we mitigate our own biases is kind of the solution part to that. So it's another great resource for your listeners, Jamie.
What are some common misconceptions about BTK inhibitors?
The main thing is teach your patients that this is not chemotherapy. And when I'm doing this teaching, I specifically use the words targeted therapy because I've learned from my patients that they thought they were receiving chemotherapy because of, maybe a handout that was given from the Hope AOCNS website, or some of them still actually say oral chemotherapy education versus oral cancer treatment education. I've had several clarifying conversations with my patients about the difference. And now I'm beginning my education by defining the difference between chemotherapy versus targeted therapy. And so that's one misconception that can be further kind of elucidated. And secondly, we touched on this a little bit, is the misconception around duration. So for the time being, BTKi inhibitors are continuous therapy. This means a lot because I can't name the number of times where I've had patients kind of surprised to hear that they were on this therapy until progression, because a lot of them are coming from fixed duration chemotherapy regimens. So it's really essential that we discuss this with our patients, that these agents are continuous. And it's just like treating a chronic disease like hypertension or diabetes.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think with oral cancer targeted therapy, we still have limited ways to measure compliance. It's really important that we educate our patients that compliance is really crucial for this class. And the non-adherence of ibrutinib has been evaluated in several studies, and they all conclude that missing more than 8 days leads to worse PFS, or a higher BTKi dose intensity leads to improved progression-free survival. Lower adherence, less than 80%, leads to less PFS or OS. And we know that non-compliance can lead to resistance. And yes, we do have future novel agents that we're looking at to overcome the resistance, but really these second generation BTKis are really effective. They're safe and they're really well designed. We should really maximize their capabilities and educate our patients to advocate for themselves regarding side effects so we can manage the toxicities with all the measures that we talked about earlier. And so educating them about adherence is really key.
What additional training or education do oncology nurses need to stay current on this topic?
For our listeners, becoming an oncology certified nurse using that OCN certification Attending ONS conferences, I'm sure you're aware about, Bridge and ONS Congress are great resources. NCCN also has a free resource for continuing education on their website. And CODA, which is a National Community Oncology Dispensing Associations, they develop these PQIs, which are positive quality interventions. And so they're quick, like 1 or 2 pages about these specific agents that can be really important to help stay current. And then EPP, which is Advanced Practice Providers, also has an oncology summit all across the U.S. Great CMEs for advanced practitioners, nurses, pharmacists, etc.
And finally, what are some additional resources that maybe patients or other providers in healthcare could use to learn more?
All these BTKIs at this time have great manufacturing websites where there's tremendous amount of patient resources. Recall the patient that we discussed about the acalabrutinib who was on a PPI. We actually explored the website together, while I was there in clinic, showing them the difference between a capsule and a tablet formulation. So I always advise patients to look at their manufacturing website. The NCCN has great patient guidelines as well, and they are a little lengthy, but they have great infographics and they're really brought down to patient education reading levels. And then Society for CLL. So CLL Society has great fact sheets. If you're looking to get deeper into the chemistry, PubChem is a great resource for compound specific details. One resource that I came across this time around while prepping for this podcast is the Video Journal of Hematology and Hematological Oncology. Great little short clips organized by disease states or my favorite medication to kind of get video highlights. And these video highlights are by PIs, by the authors, the investigators of these specific agents. So great resource. Oxford University has protocols for BTKIs, which are written by oncologists and pharmacists, available free to anyone. And then recent great publications by the Pharmacy Times in the last 6 months really are available. So there's some really great resources out there, Jamie.
Well, Puja, thank you again for just your wealth of information, your time and expertise that you shared. I know that this podcast will be extremely well received and really be a helpful resource for our nurses as they care for patients who are taking these BTK inhibitors. So thank you so much. Do you have any final comments to share with our listeners today?
I want to say thank you to the ONS team for another invitation here on your podcast. And I appreciate my organization, my leaders, and my colleagues for really supporting me to develop this ambulatory care oncology pharmacy service line, which allows me to kind of have direct patient care experiences and develop insight, and then in turn help listeners in the ONS community. And this is a really exciting space in pharmacology, and I'm honored to be here today in the first month of 2025.
Wonderful. Well, thank you again.
Thank you, Jamie.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.